to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up to date diagnosis and management of a wide array of thyroid diseases. Today's episode will be on iodine deficiency and thyroid disorders. We'll start off by exploring the role of iodine in thyroid hormone synthesis and autoregulation, then move into how iodine deficiency and iodine excess contribute to conditions such as goiter, hypothyroidism, autoimmune thyroid disease, and even impaired neurodevelopment. We'll also discuss practical questions for clinicians: when to measure iodine status, how to counsel patients in pregnancy or on restrictive diets, and the impact of iodine supplementation. Finally, we'll take a look at global perspectives, the success and challenges of iodinization programs, and some current controversies surrounding supplementation and iodine restriction in autoimmune thyroid disease. I'm thrilled to be joined today by Dr. Elizabeth Pierce, an internationally recognized endocrinologist and epidemiologist specializing in thyroid disorders and iodine disorders. She practices at Boston Medical Center, where she directs the Endocrine Fellowship Program and serves as professor of medicine at Boston University Chobanian and Avesidian School of Medicine. She has served as president of the American Thyroid Association in 2018 to 2019 and has been honored with numerous awards, including Women of the Year by Women in Thyroidology and ATA's prestigious Van Meter Award. Dr. Pierce's research spans iodine nutrition, thyroid function during pregnancy, the effects of environmental disruptors on thyroid health, and subclinical thyroid dysfunction. Her groundbreaking work has directly influenced national recommendations on iodine supplementation in pregnancy, helping to shape the way clinicians care for women and infants. Beyond her clinical and academic leadership, Dr. Pierce has played a vital global role through the Iodine Global Network, where she has worked tirelessly to eliminate iodine deficiency disorders worldwide. Thank you so much, Dr. Pierce.
My pleasure to be with you today.
Can you start by walking us through the role of iodine in thyroid hormone synthesis, including organification, coupling, and autoregulation?
Sure. So, when we ingest iodine in the diet, it's pretty readily absorbed by the GI tract and will circulate in the plasma, where it effectively will tend to meet one of two fates. So, either it's just excreted by the kidneys, or it will be taken up by the thyroid via sodium iodide symporter on thyrocytes, diffuse across the thyroid cell, and at the apical surface of the thyrocyte, the TPO and hydrogen peroxide will oxidize the iodide and will attach it to the tyrosol residues on thyroglobulin to produce either monoiodotyrosine, MIT, or diiodotyrosine, DIT, which are the precursors of thyroid hormone. And then either two DITs are put together to make T4, or a DIT and an MIT are put together to make T3. Then those thyroid hormones are synthesized. As far as we know, the only use of iodine in the body actually is in the production of thyroid hormone.
Okay. And then can you tell us what the Wolff-Keichach effect is?
Sure. So we are designed to, I think, keep thyroid hormone production fairly stable in the face of variable iodine intakes. And that sort of makes sense from an evolutionary perspective, because we did not necessarily evolve in settings where iodine was going to be available consistently, from meal to meal. So in response to a very large iodine load, you get the acute Wolff-Chaikoff effect, which is sort of a sudden shutdown of thyroid hormone synthesis. We don't know exactly how that works, but it has something to do probably with a buildup of iodolactones and iodolipids in thyroid cells. When there continues to be high level of iodine around, when there's continued exposure to iodine excess, after a few days, normally the sodium iodide symporter expression is decreased. So less iodine can actually get into those thyroid cells, and thyroid hormone production will resume. So if this homeostatic mechanism works the way it's supposed to, even in the setting of a large iodine load, thyroid hormone synthesis really won't change appreciably. But there are individuals in whom that homeostatic mechanism fails. And so you can get either iodine-induced hyperthyroidism, which is the failure of the acute Wolff-Chaikoff effect, or you can get iodine-induced hypothyroidism, which is a failure of the normal escape mechanism.
How often does that happen? Because it seems like this is a very protective effect.
It probably happens more than we know. We certainly give huge iodine loads to almost everybody who comes into the hospital and has, some kind of iodinated contrast study, but it often may not be clinically significant. But certainly, studies that have looked at this prospectively were probably inducing transient thyroid dysfunction and more patients than we are aware of, mostly from CT contrast.
Thank you. So we talked a little bit about acute, but what about more chronic? So if we're looking at chronic iodine deficiency, what are like the implications of that?
Yeah, so we've talked about iodine excess. Iodine deficiency, um, the clinical effects will really depend on the degree of iodine deficiency and on the duration. And even, within the same, geographic setting where there may be very low iodine nutrition, there's a lot of intra-individual variability in people's ability to adapt to it. But in severe iodine deficiency, initially the thyroid can compensate to some extent even when iodine intakes are quite low. There's some iodine typically stored in the thyroid, and then beginning sort of stages of iodine deficiency will trigger an increase in TSH as thyroid hormone production drops, and that TSH stimulation will actually increase sodium iodide supporter expression, so help the thyroid become more iodine avid. And the TSH also tends to preferentially stimulate production of T3 rather than T4 at the thyroid. It takes less iodine, so it sort of helps preserve the iodine that's available. So, in mild iodine deficiency, those compensatory mechanisms may be fine, and thyroid hormone synthesis can be maintained. But as iodine deficiency worsens, or as it becomes more chronic, the thyroid may be depleted of that stored iodine, or these homeostatic mechanisms really just are not sufficient to continue to cope. And so you might start seeing a decrease in thyroid hormone production. Also, that TSH stimulation of the thyroid, can over time trigger goiter. And initially simple goiter with iodine deficiency, but over time, if that's persistent and chronic, many individuals will start developing nodular goiter, and then in older individuals, those nodules can sometimes become autonomous. So, those are sort of the effects on thyroid hormone production and thyroid size. But from a public health perspective, probably the most critical effect of inadequate iodine nutrition is the effect on the developing fetal brain. That we know that optimal iodine nutrition and optimal thyroid hormone levels are really essential, probably especially in the first trimester of pregnancy for normal neurodevelopment. And so, in severely iodine deficient regions, children can be born with intellectual impairment. In very profoundly iodine deficient regions, children can actually be born with the syndrome of cretinism, which would include intellectual impairment, but also often deafness and impaired growth and other kind of metabolic disorders.
So essentially, severe iodine deficiency in pregnancy can lead to congenital hypothyroidism.
Congenital hypothyroidism and cretinism, which is different because in iodine deficiency in pregnancy, both the mother and the fetus have impaired thyroid hormone production because both the maternal and the fetal thyroid will be unable to function properly. Whereas in congenital hypothyroidism, typically the maternal thyroid is normal, and it's really only after birth that the offspring is profoundly hypothyroid. So the neurologic sequelae of iodine deficiency may be far more severe than the sequelae of just isolated congenital hypothyroidism.
So is any of this reversible? We'll start with the thyroid nodules. Like if you get this nodular goiter from the iodine deficiency, can you just give iodine and it'll regress?
If you catch it early enough. The very first clinical trial to look at this was that of David Marine in the 19 teens, more than 100 years ago now. And they did exactly that experiment. They supplemented iodine in schoolgirls, high school age girls who had goiter, and the goiters regressed. So when you're at the initial stage where you've got simple goiter in an iodine deficient setting, you can give iodine back and the thyroid sizes will shrink. But in people who have chronic, long-standing goiter, whereas you might imagine there's a lot of not a lot of nodularity and fibrosis, that probably is not going to be reversible at that point.
And how far before pregnancy? So is this reversible in pregnancy or you have to I know probably in the first trimester, but ideally even before?
So, iodine is needed for neurodevelopment with probably a very critical window in that first trimester. But thyroid hormone continues to be important for ongoing brain development, probably throughout pregnancy and probably up through the teenage years. We know there's, very rapid neurodevelopment in the first 3 years of life, but it continues out into the teens and maybe early 20s. My kids are that age. I'm pretty confident that there's still brain development going on. So, I think the reversibility of the effects on the brain are not so clear. There have been a couple of randomized trials in school age children who presumably grew up in regions that were iodine deficient, probably were developed as fetuses in mothers with inadequate iodine intakes. And, in that school age time frame, iodine supplementation was actually able to improve some of the cognitive testing. But there probably is a certain amount of this that is not reversible.
Okay, so better if we treat it earlier, but we should always try to treat it if possible.
We should try to prevent it ideally rather than needing to treat it down the road. Yeah.
Let's talk a little bit about iodine excess, the opposite of it. I know you kind of briefly touched on it. Can you talk about how excessive iodine, so if we overtreat it, how does that lead to autoimmune conditions, Graves' disease?
So, iodine excess, again, we've got these nice built in homeostatic mechanisms, and many people will tolerate a fair amount of excess fairly well. The RDA for iodine in non pregnant adults is about 150 micrograms a day. And for adults in the US, the tolerable limit, the sort of the amount of iodine that you can ingest chronically on a daily basis without, in most people, triggering thyroid dysfunction, is 1100 micrograms a day. So there's a fair amount of leeway there. WHO has set that upper limit in pregnancy and lactation more conservatively at 500 micrograms a day. So your life stage may, to some extent, determine how much iodine is really a safe intake. But most people, with the homeostatic mechanisms we have, do fine. Patients with underlying mild Graves' disease may have hyperthyroidism that gets dramatically worse in the setting of a big iodine load, sort of adding fuel to the fire. Individuals with underlying nodular autonomy, that hyperthyroidism may get substantially worse. They don't have, feedback loops that are working properly. And so um, seems somewhat contradictory, but in fact, it's the parts of the world that are historically iodine deficient where you have more toxic nodular goiter in the population, where you're actually more likely to see hyperthyroidism as a result of excess iodine exposure, or even of moving iodine intakes from sort of a low range to an optimal range. So, Graves itself, probably not triggered so much by iodine intake, but it certainly can be worsened in the setting of excess iodine. Excess Excess iodine can also cause goiter, as for most nutrients. There's a U-shaped relationship between intakes and health outcomes. So too little is not good for you, but too much is not good for you either. Excess iodine can be associated with higher risk of hypothyroidism and of goiter.
Thank you. There was one other topic that I wanted to cover with iodine. So I treat a lot of thyroid cancer patients, and lots of patients ask me, is iodine going to make my thyroid cancer worse, or is iodine deficiency the reason for my thyroid cancer? So can you talk a little bit about if there's any evidence linking iodine status, either deficient or excess, to thyroid cancer, and what do we know?
So the data are messy. There are some older kind of ecologic studies that suggested that perhaps when iodine deficiency is corrected and populations become more iodine sufficient, that there's a shift in the types of differentiated thyroid cancer, from more follicular cancers to more papillary cancers. However, in the same time frame when those studies were being conducted, in many parts of the world, we saw just sort of a dramatic increase in risks of and rates of papillary thyroid cancer. So it is not entirely clear in retrospect whether those two trends were connected. In some parts of the world, for example, in China, there has been a backlash against salt iodization because care providers noted this huge increase in papillary thyroid cancers at the same time that China happened to be iodizing its salt and the population iodine status increased. So there was a concern that perhaps this was due to optimizing the iodine nutrition and it was a side effect. I think the clear counter argument to that is that over the same time period in the United States, we saw a radical decrease in the amount of iodine that the population was ingesting. It probably decreased by about half between the 1970s and the 1990s. And in the US, over that same time period, we saw the same increase in papillary thyroid cancer diagnosis that we saw in China and in other parts of the world. And so I think those two trends are probably not necessarily connected. Now, it's not to say that there's no influence of iodine intake on differentiated thyroid cancer risk. There are some newer studies that suggest perhaps, as for other thyroidal outcomes, there may be a U shaped relationship, and that iodine intakes that are both too low and too high may be associated with slightly increased risk for thyroid cancer. It might make sense because TSH levels, when iodine is too low or too high, might be increased, which might be a growth factor for thyroid tumors. So I think that this remains a little bit unclear, and we don't really have good long-term prospective studies to examine this question.
So something that can be done research wise in the future for our cancer patients. We talked about high and low. So I actually wanted to go through like how do we evaluate for active iodine status? Is there a test that's one test is better than another, and who do you test in?
So, very sadly, there is no individual biomarker for chronic iodine intakes. I really wish that were not true because it would make life much easier as a clinician and it would also make life much easier as a researcher. But what we have are guidelines from the World Health Organization that provide ranges for median urinary iodine concentrations for populations. So at the population level, we can assess iodine status using urinary iodine concentration. But at the individual level, we really can't because for all of us, urinary iodine concentrations vary really day to day and even hour to hour. They really reflect what we've ingested in the last few hours. And most of us are not eating sort of consistent amounts of iodine hour to hour, day to day, meal to meal. So it's been calculated that to really understand an individual patient's chronic iodine intakes with even 20% precision, you would need 10 to 12 spot or preferentially 24-hour urinary iodine concentration measurements. And I have personally never met a patient who would be willing to do 10 to 12 24-hour urine collections. So, practically speaking, we do not have an individual biomarker. And so to try and understand iodine status, sort of habitual iodine intakes in the diet, our best clues are going to be asking about sort of key sources of iodine nutrition. In the United States, iodized salt is one of those key sources. It has been globally an enormously effective public health measure in optimizing iodine nutrition in iodine deficient settings around the planet. In the US, we iodized our salt 100 years ago, more than 100 years ago. It was 1924. Nobody remembers what severe iodine deficiency looked like in this country. We have forgotten. Nobody really knows why that's in the salt anymore. And maybe as a consequence, iodized salt intake has dropped dramatically in this country. So only about half of the household salt sold in the US is actually iodized these days. And in fact, most of the salt we ingest is not in what people are adding at the table or adding when they cook at home, but it's in commercially processed foods, and those typically do not use iodized salt. So you can ask about use of iodized salt, but that may not be the whole equation. The other really major source of iodine in the US diet these days is dairy foods. And the iodine is not in dairy foods as a public health measure for humans. It's there as a public health measure for cows because it turns out dairy cows don't produce very well when their iodine nutrition is not optimal and they're hypothyroid. So the dairy farmers figured this out decades ago, and the cows get iodine in the cattle feed. There's also some iodine that gets introduced into the milk supply through the use of iodophore cleansers in the dairy industry. But dairy has probably become an extremely important source of iodine in the US. And so I think probably the two key screening questions, if you're trying to establish whether somebody in this country might have inadequate iodine intakes, One is, do you use iodized salt when you add salt to your food? Do you have any dairy foods in your diet? And if the answer to both of those is no, um, there's a reasonable chance that iodine intakes may be inadequate, especially for women who are pregnant and lactating who need more than the rest of us.
So, in those groups of population, say you answer no to both of those questions, you just go ahead and empirically treat the patient then? Is there something that you would recommend, especially if they were pregnant?
So, the American Thyroid Association and also the American Academy of Pediatrics both recommend that in the US, where we have seen a reemergence of mild iodine deficiency over the last 15 years, specifically in pregnant women, that just to be on the safe side, women who are, planning pregnancy, actively trying to conceive, women who are pregnant and women who are lactating should take a daily supplement that contains 150 micrograms of iodine. So those recommendations have been around for almost 20 years. Uptake has not necessarily been optimal. Not everybody knows to look for this. And in fact, of all the different varieties of prenatal multivitamins sold in the United States, only about 60% contain iodine. And the ones that are marketed as prescription products, for whatever reason, are actually far less likely to contain iodine than the ones that are sold over the counter. So the recommendation across the board is, for women, again, pregnant, planning pregnancy, lactating, to take a daily prenatal vitamin that contains that 150 micrograms of iodine. And I think for individuals who don't use iodized salt and who don't ingest any dairy, sometimes people following a plant-based diet, or people who are lactose intolerant, for example, it is reasonable to suggest a daily multivitamin that contains 150 micrograms of iodine. The prenatal vitamins do not all contain this, but actually the majority of the non-prenatal multivitamins do.
Yeah, I really struggled with this myself is that you have to read the nutrition label on the prenatal vitamins since not all of them actually have iodine in them. So I think that was an important thing that I personally learned being a thyroidologist is that it might be harder than it looks to get a prenatal vitamin with iodine in it. But there is some stuff out there. So just make sure you read the content of the prenatal vitamin or use a multivitamin if you're unable to successfully get one with iodine in it. For people who are not pregnant, would you ever recommend just empirically having iodine supplementation, or would you more advise them on ways to improve their, diet to obtain it?
Yeah, I think it's generally good advice. We don't want people to add additional salt to their diet. We have to sort of balance iodine nutrition with concern about cardiovascular risk. But I would say anybody who is using salt should just look for iodized salt and be aware that sea salt, kosher salt, that fancy pink Himalayan salt, usually those are not iodized. So you actually do need to look at the label and see what you're getting.
Kinda conversely, because I do, again, have a lot of thyroid cancer patients that go on a low iodine diet. Can you give us some tips on patients who need to go on a low iodine diet? I know Thika has a great cookbook, but just some basics. And patients always ask me, is it worth staying on it long term, or is there any harm that 2 weeks does being off of it?
Yeah. So being on a low iodine diet for 2 weeks is not going to have long term health consequences. 2 weeks is a pretty short interval. And I don't know of a patient I've ever met who really wanted to be on the low iodine diet for the long term because it'd be restricted and kind of very annoying to try and get that right. The American Thyroid Association has a good website with information about the low iodine diets. Thika has recipes and good information on the website. But really, the utility of the low iodine diet is really exclusively for preparing patients for radioactive iodine scanning and radioactive iodine treatment. There is no health benefit for patients without or with thyroid cancer of being on a low iodine diet for the long term, and in fact would not be advised for the long term in people with a functional thyroid because the thyroid again needs some iodine.
So just to clarify, is there a blood test for iodine status? I know we talked a little bit about urinary testing.
Yeah, so you can measure iodine in the blood. It's a little bit more challenging to measure it accurately, and most labs are probably going to be better equipped to do urinary iodine. Like urinary iodine, serum iodine levels are going to vary following recent meals, and so they also are not of any utility for really understanding chronic iodine intakes. And I think the only real use of urinary iodine concentration measurement in the clinical setting is when you have a patient who has received a big iodine load recently, had a CT scan, cardiac catheterization, something like that, where there's contrast media exposure, and you need to do radioactive iodine scanning or radioactive iodine treatment. We know from prospective studies that our group and others have done that most of the time, urinary iodine concentration come back down to approximately baseline about 4 to 6 weeks after that typical iodine load. So you can just wait for that interval. But if you want to be really sure that the iodine load has cleared before you're going to try and scan or treat with radioactive iodine, it's reasonable to get a urinary iodine, and I think a spot urinary iodine concentration is just as useful as a 24-hour urine concentration in that setting. You're just looking to see if there's sort of ongoing high level that's persistently there. And so that is the one time when I occasionally do order this.
So does it have to be normal, just to clarify? Or if it's not normal, if it's high, how long do you wait for repeating it?
So normal is a tricky concept, right? The lab might give you that, but we don't have a normal for individuals. So I try and just make sure it's sort of somewhere around the US median or lower. So, if it's somewhere in, less than 200 micrograms per liter, ideally less than 100 micrograms per liter, I think is probably okay to proceed. But if it's still 400, 500, something somewhere in the thousands, then you have to wait. And if you do that testing and it's still really quite high, I'd wait another 2 or 3 weeks and test again.
So we talked a lot about on the individual level. Can you talk about a little bit on the population level? How is this ionized salt requirements both in the US and internationally kind of rolled out? What have we learned? Different lessons that we've learned from the rollout in
Yeah,
different
we've
countries.
learned a lot, and it's this amazing public health story that people really seem not to know anymore. So, in the 19th century, before there was salt iodization anywhere, large parts of the planet were iodine deficient. Effectively anywhere on the globe that's had a lot of glaciation or flooding, where the iodine has eroded from the soil, is prone to have low iodine nutrition. So there was a so-called goiter belt in the United States. It was right across the Great Lakes regions, sort of extending to the Pacific Northwest. But really, most countries around the world had at least regions of low iodine nutrition. And it wasn't understood what this was for a long time. There were many, many hypotheses. Lack of sunlight. Is it infection? Is it something nutritional? Is it consanguinity? All kinds of crazy theories were sort of put forward in the 19th century. And it was David Marine, who I alluded to earlier, who did the randomized trial in the 19 teens that really demonstrated that what was known then as an endemic goiter was really a manifestation of low iodine in the diet. So in the US, very shortly after his work was completed, we started iodizing salt. In Switzerland, they started iodizing salt at almost exactly the same time. But nowhere else really did this for a long time. And in 1993, the World Health Assembly passed a resolution that as a global public health community, we should be committing to trying to eliminate iodine deficiency disorders by using iodized salt because we knew there was an intervention that worked and it's cheap. It costs pennies per person per day to do this. So there was a real push by governments and by international agencies starting in the early 1990s. And in 1993, when this resolution was passed, 110 countries around the globe were considered to be iodine deficient. By you know 2023, the most recent year for which we have kind of an official iodine map, we're down to only 20 countries that are considered to be iodine deficient. And the countries that have iodine deficiency these days are largely sort of mild to moderate iodine deficiency, not the severe iodine deficiency that was present in many parts of the world decades ago. So it's been this tremendous public health intervention. We did a study in 2019 that sort of looked back at the likely impact of these salt iodization programs globally and calculated that the global prevalence of sort of clinically apparent iodine deficiency disorders fell from 13% to 3%. This translates into about 720 million prevented cases over that time interval, or about 20 million newborns that are protected annually. And because of the importance of iodine nutrition for IQ and the importance of IQ for driving economies, we sort of calculated that this had translated into a global economic benefit of about $33 billion. So not just improving, individual health outcomes, but whole societies and whole economies. But all this work has been ongoing over decades, and people are starting to forget why this is important and scaling back on a commitment to funding these salt iodization programs. So, what we are seeing in some countries recently, including in the US, where we never mandated salt iodization, is a reemergence of iodine deficiency, often in the most vulnerable populations, young children and women of childbearing age and pregnant women. So, one thing we've learned is that this is a very effective intervention. But another we've learned is that it really has to be sustained for the long haul, that you need sort of ongoing education for the public and for healthcare providers and government ministers to understand that this is something that has to be carried forward.
That's one of the reasons actually I wanted to do a podcast on it, because we have to keep bringing awareness to the topic. Should we forget, what it was like 100 years ago, and then we're back to square one. Is there anything else besides education that would really help either worldwide or in the US to kind of get us that last little bit?
A lot of the countries where we have persistent iodine deficiency are countries where there isn't legislation requiring salt iodization. So I think um, that really does seem to work very well in the countries that employ it. So I think that's one lesson, that sort of really mandating it is a very helpful way to protect populations, and then you don't necessarily need to do as much education about what choices to look for on the grocery shelves.
So just for clarification, the US is not mandated.
Nope.
We did the huge push without an actual mandate.
Yeah, no, it's always been strictly voluntary on the part of salt producers. There was an attempt in the 1940s to actually mandate this through Congress, and that did not pass. And so we have been sort of relying on this voluntary system ever since.
Interesting. Do you think that on the upside that mandating it could have any sort of long-term effects as far as overtreatment? Are we very, very far from that? Like as far as autoimmune conditions that we had talked about earlier?
Yeah, so there always are risks and benefits of every intervention. Certainly, when salt iodization programs are rolled out, and we know this from historical data from the US, but that was done before we actually even had reliable thyroid function tests. So we know this better from more recent interventions in other countries. Denmark is maybe the country that studied this most carefully, and they mandated salt iodization in the year 2000, and they did it very carefully to bring their population up from sort of mild to moderate iodine deficiency to just in the bottom end of the optimal level. And in doing that, they initially triggered an increase in hyperthyroidism. Figures probably older individuals with autonomously functioning nodules as a result of long term iodine deficiency. This hyperthyroidism was worse, and effectively, this condition was unmasked. But after 10 years of salt iodization at the same level, in fact, that initial transient wave of increased hyperthyroidism resolved. And in fact, the rate of hyperthyroidism in the population declined to about a third lower than the baseline levels before salt iodization. So there's often a transient phase where you will see an increase in hyperthyroidism in the population. There are also some countries where there has not been probably careful enough monitoring of the salt supply, or where sort of levels of salt iodization that are too high maybe have been elected, and countries have been tipped into iodine excess, which again can cause more hyperthyroidism, but also more hypothyroidism or goiter. So important to get the balance right, and importance to sort of monitor both populations and salt producers to make sure that levels are staying where they need to.
And speaking of that, so on the individual level, lots of patients come in and I don't know for you, but they ask me about iodine tablets. Should I be taking supplementation? Or we do have some diets around the world that have a lot of iodine in like seaweed or kelp products. If your patient were to come in with these kind of questions, what risks should clinicians be aware of actually stuff that's out there?
Yeah, and again, sort of optimal iodine intakes are in the microgram range. So 150 micrograms a day for a non-pregnant lactating adult, somewhere between 220 and 250 micrograms a day in pregnancy, and somewhere between 250 and 290 micrograms a day for women who are breastfeeding, where iodine is actively secreted into breast milk. And many of the supplements on the market, particularly those kind of labeled for thyroid health, may have iodine content that has a daily dose that's not in the microgram range, but in the milligram range. So orders of magnitude sometimes above true physiologic requirements. And it is quite easy, I think, to ingest too much iodine in those settings. Probably the ability to tolerate high levels of iodine may have something to do with sort of chronic iodine exposures. And in some parts of the world, like Japan and Korea, there's probably a pretty high level of iodine exposure from seaweed consumption, starting in utero and sort of going throughout life. So the ability to tolerate high levels of iodine may depend, historically on what people are used to seeing, and you may tolerate it a little bit better if you've had it right along. There are in the literature reported cases of lactating women having seaweed soup, which is very commonly recommended in some cultures, having very high breast milk iodine levels and inducing iodine induced hypothyroidism in their breastfed infants. There are reported cases of women, actually, some we reported in this country, who were advised to take very high level iodine supplements during pregnancy and had children born with high blood iodine levels and hypothyroidism that was thought to be related. So it is possible to overdose fairly easily. And it's hard to find that 150 micrograms of iodine a day that's a really kind of physiologic dose in over the counter supplements. So it's actually much easier to find it in a prenatal supplement than in something that just contains iodine. Often those are levels that are too high. Seaweed also, very variable, depends on the variety of seaweed, depends on the location, depends on the time of year. So there's actually quite a lot of variation in the amount of iodine in seaweed. But some seaweeds really contain very high levels and generally would recommend against seaweed as a source for iodine nutrition because it's easy to sort of get more than you really need and potentially enough to trigger thyroid dysfunction.
Okay, so we talked a little bit about supplements. Where do you think the research is heading for iodine deficiency or iodine excess in like the next decade or so? I mean, we've done a lot on the global health perspective. More needs to be done, but is there any other opportunities for research?
I think the field would love to develop an individual biomarker that, as I said, it would make our life easier as clinicians. It would also make life easier as a researcher of iodine nutrition. There's a lot of interest in exploring this, but as of yet, we don't really have anything that's been validated or has been useful. At kind of a public health level, there's a lot of interest in trying to figure out how best to monitor populations over time. That once you iodize the salt, again, if you're not paying attention, the population can drift into iodine intakes that are too low or too high. So you do need to watch. And the WHO guidance currently recommends doing large sort of population based surveys of across countries every 5 years, which is a really expensive undertaking and not necessarily something that's very practical for many settings. So there's interest in trying to figure out, are there more targeted ways to sort of understand population iodine status? Could it be sort of looking at newborn TSH levels in countries that have neonatal congenital hypothyroidism screening, maybe as sort of a trigger to look more carefully at population intake if rates of congenital hypothyroidism change? Could it be really trying to target the most vulnerable population, which is maybe pregnant women in antenatal clinics, specifically rather than doing broad population based surveys in school aged children? So we don't know exactly what that needs to look like. And I would say that the last thing that I think is a really important research need is that we unequivocally know from trials that were carried out in the 1960s and 1970s, and even those trials back in the 19 teens of David Marine's, that if you optimize iodine nutrition in severely iodine deficient regions, you will increase population IQ by somewhere around 13 points, which has really remarkable downstream implications, as I've said, for not just individuals, but for whole societies. You will decrease rates of obstetric complications, miscarriage, stillbirth, perinatal mortality rates decline. You eliminate the possibility of cretinism, and you reduce goiter and rates of hypothyroidism across the population. So we know in severely iodine deficient regions that you have all these tremendous downstream benefits from optimizing iodine nutrition, either with supplementation strategies or with food fortification. What we do not know is whether optimizing iodine nutrition in more mildly iodine deficient regions confers, clear benefit. And we don't really know that, mostly because we don't really have good trial data. Have only one trial to date that's looked at optimizing iodine nutrition in pregnant women in sort of mildly iodine deficient region. That did not show effect on child IQ and offspring, but it turned out it was actually done in a part of the world that had optimized iodine nutrition via iodized salt before the study started, and it wasn't really the right population at baseline. So we don't have good trials to understand whether in these more mildly iodine deficient settings, improving population iodine intakes improves child IQ, which is, I think, the public health outcome of most interest. We do have observational data sets that strongly suggest that that might be the case.
Maybe just not as big as the gap that you're gonna see with the severe deficiency.
Right. So one would expect, IQ increments to be more subtle, and the studies haven't really been done to carefully look for that.
And I'm kinda curious, who's doing all these population-based surveys? Is this all volunteer or is in the United States who's doing the surveys?
So in the United States, it's actually been done by the CDC. It's part of NHANES since the early 1970s. And so that's how we know that our iodine nutrition kind of nosedived between the 1970s and the 1990s, and how we know that iodine deficiency has reemerged in pregnant women. But in most countries, to do sort of national surveys, it's the health ministry or some kind of government agency that conducts these. And again, there's a cost associated with doing that.
Well, thank you for joining us today. For our listeners, is there 2 or 3 clinical pearls that you'd like, internists as well as, endocrinologists and fellows to remember about iodine and thyroid health?
So maybe I would start with noting that severe iodine deficiency has absolutely devastating effects, especially in early life, and that even mild to moderate iodine deficiency in observational studies seems to be linked to poor child cognitive outcomes. So this is something that really matters. That the second point might be that unfortunately we do not have an individual biomarker for looking at chronic iodine intakes. And therefore, we have recommendations to prescribe supplements for high risk populations, especially preconception, pregnancy, and in lactation, in settings where we think there may be even mild degree of iodine deficiency, or for individuals who may have restricted diets, who might not be ingesting iodine that's adequate even outside the pregnancy setting. So, again, the recommendation for those individuals who may be at risk is 150 micrograms daily in a supplement.
Thank you. And thank you again for joining us. For our listeners, please stay tuned to future episodes on medullary thyroid cancer treatment options and active surveillance for micropapillary thyroid cancers.